Nerves go to the, of course, they go to the muscles and they go to the tendons. Not that many nerves in the tendon, but if the tendon is injured, then you have more nerves. It's interesting, a lot of these tissues that are aneural and the lack of blood supply, like the ligaments and the tendons, joint capsules. Once you're injured, there is a blood supply, and nerves are there, and sometimes those are the areas of concern. Tendinosis, tendinopathy, chronic pains in the tendons, they tend to degenerate on their own with age. I feel if we can get blood into these tendons, they'll respond. Blood into the nerves, and then the nerve in turn controls blood supply into the tendon itself. Biopsies of these tendons of tendinopathy, these tendons that are, have that condition, expanded extracellular matrix, edema, lack of blood elements, so it's avascular edema, and way too much proteoglycan, which in my opinion attracts the fluid in there. Pump out, so what we're going to do is we're going to pump out the fluid. By stretching the tendon, by stretching the nerve, we're actually, in the short term, increasing the pressure, which moves the fluid out. Then when we finish the procedure, the resting hydrostatic pressure is less, blood flows in there, warms up. Achilles tendon. Sometimes people can just step off a stair or do a wrong step, the Achilles tendon is torn. This tendon's probably been degenerated for some period of time, getting worse and worse and worse, and finally it goes. Now the nerve to the Achilles is part of the tibial nerve and the lumbosacral plexus, but I'm not going to bend the entire leg up like I showed you for the large nerve. But sometimes I may have to, but most often I don't. I can bias the nerve just down in the end. Slide backwards a bit. Our Achilles tendon's underneath here. Slide down back a bit. Okay. It's almost like I'm forcing the tibia. Feel that? Mm-hmm. Or I can increase it. Pressure on, pressure off. Pressure on, pressure off. Achilles tendon, mid-tendon tendinosis, eccentric exercises works okay. But the insertion of the Achilles, eccentric exercises don't work okay. Distraction of the calcaneus seems to work. So we can adopt this procedure where we can distract the calcaneus for the insertional Achilles tendinopathy. Let's slide back a bit. Okay. Now this time I'm pulling the heel down and then up. We'll get a helper. We'll get a helper to actually dorsiflex the ankle at the same time. So quite a stretch on the nerve. Just grab here. And I'm pulling up and pressure on, pressure off. Normally I wouldn't be looking at the camera, I'd be looking at the patient's eyes. How are you doing? Mm-hmm. She tells me everything. Yeah, you can just remain there for a second. Achilles tendon and plantar fascia are related. Plantar fasciitis, if it's a chronic, if it's not in the inflamed state, we might be able to increase the blood supply to the plantar nerves in the sole of the foot. Similar procedure, but this time we dorsiflex the ankle, or we try and stretch the fascia at the same time. So this time I'll have you pull just underneath it, right underneath there. And pull. More of a fascial, are you all right? Mm-hmm. Fascial stretch. Right. Morton's neuroma. Osteoarthritis of the great toe. Flex the toes more. Okay. Now by lifting the heel, I'm stretching the plantar nerves, and she's doing even more so at the top. Now I'm not saying all Morton's neuromas will be cured or will be helped, but what exactly is a Morton's neuroma? Some respond, some don't. So they might say the variety of conditions, they can call them a Morton's neuroma. You may have to, Morton's neuroma, you may have to flex the toes, or you may have to put them apart. But we're stretching nerves. So, Achilles tendon, assertional Achilles tendon, plantar fascia, transverse arch, that anterior, or that metatarsalgia, same idea, toes back. Traction and up, metatarsalgia. How will you know if this procedure will help a certain condition? I got to try it and see. Some conditions aren't mechanical. Some conditions you have to be careful of, like an inflamed condition like cancer, for example, or rheumatoid arthritis. You want to be careful of. Okay, we'll move up. We did the kind of the calf and the Achilles. Popliteus. Little muscle. Affects the back of the knee. Popliteus tendon is no different than any other tendon in the body. External rotation, extension of the knee, pressure on, pressure off. Pressure on, pressure off. Feel that stretching behind your knee? Pressure on, pressure off. Popliteus muscle. The knee joint. The knee joint is different than the ankle joint. The knee and hip joints are different than the ankle joint, and the knee joint is innervated by both the lumbar and lumbosacral plexus, where the ankle joint is the lumbosacral. So lumbar plexus is in front of the hip, lumbosacral is behind the hip. So some procedures when we're loading tendons around the knee joint, hip flexion, others are hip extension. Outside of the knee, iliotibial band, tensor fascia lata, glute med, superior gluteal nerve, and tensor fascia lata, the tendon. So let's work on that one. We're going to stretch this. When the muscles get a little bit longer, the tendons, the muscles are longer, then I might have to do a muscle energy technique to get that muscle lengthened before we can target into the nerve. Now very gently pull this leg back and relax. Muscle energy technique for TFL. Back and relax. Long axis traction. I can have somebody hold the hip down or have it with the belt. You can hold the hip down if you like in the chest. And pull the leg back a little bit and let go of the whole leg. Okay, pull it back and let go. Whereabouts do you feel that stretch?
Right in my hip.
In the hip. Now if she had the pain in the knee, right I don't have quite the right position, so I'm going to change it around. Position for everybody is different. The only way I can tell which position is correct is what the patient tells me. They tell me everything. Let's try it up a little higher. Where's that one?
It's almost in my hip.
And that one?
Yeah, that's the knee.
More into the knee. So for her, this is the position. So pressure on, pressure off. Pressure on, pressure off. Get a warming sensation in the IT band, or the outside of the knee, or the hip, depending on where the superior gluteal nerve is affected. While we're on the knee, little blood vessels inside the knee, joint capsules and that, just like the anterior drawer test or the drawer test. This is a great non-force way to start with the knee. Pressure on, pressure off, pressure on, then go the other way, just like a drawer test. Older people in particular, this seems to work quite well because we don't have to take the knee to an end range, just in the middle of the joint place here, and we're just stretching the nerves at that point. The nerves and the ligaments or the tendons that really aren't supposed to be there, but maybe are there after degeneration. If she has pain on the inside of the knee, has pain on the inside of the knee, I might want to rotate her foot like this and pull the knee in that direction. So it's putting the stress on the inside part of the knee and pushing down. If she has pain on the outside of the knee, I might want to internally rotate it. kind of pull the knee to the outside of it. So I'm stretching those target area until she reproduces, the pain gets reproduced, and then push down as well. With this procedure, you can decrease the amount of flexion in the knee. That's going to change it a little bit. But you can actually feel that tibia sliding on there. Back of the knee pain, we went for popliteus, but there's, we haven't done the adductors yet, but the course of hamstrings, semimembranosus, semitendinosus, the two long adductors, two joint adductors. Long muscle, so press into me a bit and let go. Press into me a bit and let go. See if they can start to stretch that tendon out. Biceps femoris. Push into me a bit and let it out. Push in a bit and let it out. Adductor, which is on to the adductors, the adductor nerve, which is part of the lumbar plexus. Now you want to extend that hip. Stretching nerves and the tendons. Proteoglycans produced by nerves under stress. Proteoglycans produced by connective tissue that houses the nerves. Smooth muscle cells also produce proteoglycan. That's interesting. Huh? Okay, very gently push into me and let go. Push in a little bit and let go. Now the amount of abduction and the amount of flexion or extension depends on the patient. I want to reproduce the pain in the knee. And once I have that, then pressure on, pressure off, pressure on, pressure off. Blood starts going in there and the knee feels different. Are all knee problems going to be helped? No, of course not. But the ones that you can help, it's great. Patella tendon, kneecap, malacia, chondromalacia, subpatella, chondromalacia patella, femoral nerve. So we did the obturator nerve. We did the femoral nerve. It's going to be, we did this already. We have to be very careful with this one. We have to be very careful with this procedure because when we do the post-isometric relaxation, we don't want the patient to hurt themselves. So when I say extend the knee now, if they push too hard, they'll hurt themselves. So I practice with them. And I want you to extend, to push it to my hand very gently. No, way too hard, very gentle. Oh, now when they got the idea that it's gentle, now you're going to have to grab this knee for me. Now, push into me a little bit. Ah, that's it. Then I do traction, extension, and flexion. And now I want them to straighten the knee. And I want you to lift the leg up at the same time and relax. Okay, go ahead. Up and relax. Up and relax. Traction this way as well. Femoral nerve. Again, because we have an extreme range of movement in the knee here, and if they have some damage in the knee, if they resist too hard against us, they're going to injure their knee. So it's important that they, when we do the muscle energy technique, it's very gentle. I don't use this technique that often, but sometimes you have to.